already gone through this. You're going to be tired of hearing definitions of PNES. You're hearing definitions of PNES all day long. But basically, like we've said, PNES episodes are episodes where there's a behavioral change, can look very, very much like epileptic seizures, but they are not. And the one differential that we can make is that there are no abnormal electrical discharges of the brain during a PNES episode, while there are during an epileptic seizure. Like we've said, typically associated with stress, it can almost be called stress seizures, even if you're not aware that you're stressed. And in adults, very, very common to see an overlap between trauma and PNES. It's a dissociative episode. It's a dissociative mechanism that you're seeing during an episode of PNES, where basically there is such an overload of stress and emotion that's disconnected from your awareness, that it leads to this splitting of consciousness. So often patients will report that they can continue hearing what's being said, but they can't respond. So there's an altered consciousness. It's not that you're completely unconscious, it can also happen, but typically there's an alteration in consciousness is what you'll see. And a really important thing is that PNES is not a single entity, so it's not really a diagnosis in itself. It's a diagnosis that's given because the patient has seizures, but it's associated with a whole bunch of other psychiatric comorbidities. So you might have, and you'll see that there's often depression or anxiety or other kinds of disorders that are also present. And then there's this unusual symptom of seizures that are not caused by epilepsy. DSM-5. DSM-5 new, this is the psychiatric Bible in a way, and this is the newest version that came out. And the definition of PNES is now listigical symptoms disorder, FNSD. And to have PNES, you need to have one or more symptoms of altered voluntary motor or sensory functions. B, clinical findings, symptoms should be incompatible with a medical or mental disorder. C, the symptom or deficit is not better explained by another medical or mental disorder. D, it causes significant distress or impairment in social, occupational, or other important areas of life. And the number assigned to PNES is F44.5, which is conversion disorder with seizures. Okay, so that's risk factors. We've already talked about this a little bit. Risk factors, main risk factor with adult PNES is a history of traumatic or adverse life events, including significant health issues, physical, sexual, emotional abuse, major losses, deaths, in particular, for example, death of a child, and other major losses, for example, going through hurricane. Recently, we've had a few patients who went through Sandy, and it was completely disrupted their lives and have not come back yet. And that appears to have been, for those particular patients, a trigger. And there's often a history of psychiatric disorders, including depression, anxiety, post-traumatic stress disorder, PTSD, and personality disorders. And there's a history in many patients, not all, of medically unexplained symptoms. So the main psychiatric issues that you might have if you have PNES, doesn't mean that you're having all of it, but that you might have depression, so you might have been given this diagnosis, depression, anxiety, PTSD, dissociative disorders, personality disorders, pain syndromes, or other medically unexplained symptoms. And then alexithymia, which we talked about, it's not a psychiatric condition, but it's a symptom or a way of functioning, emotional dysregulation, and stress coping difficulties. The main psychiatric issues, depression is a very common comorbidity with PNES. Unipolar, meaning just straight out depression, or bipolar, meaning depression and manic episodes of mania. has been seen, depending on which study you look at, in around 57% to 85% of patients with PNES. It also makes sense, once you develop PNES, that depression might develop or might get worse because of everything that we talked about. There's a lot of associated limitations after you develop these seizures. Approximately, again, depending on what study you look at, 11 to 50% of patients with PNES also will carry a diagnosis of an anxiety disorder. And a very serious number here, up to 25% have made a suicide attempt. There was one study that looked at that. So often when patients are seen in hospitals or emergency rooms and dismissed, this is not a serious condition, or I need this bed, this hospital bed for a real patient. Very, very upsetting. Upsetting to me. I can only imagine to someone who's going through that, because this is a very serious health disorder, and it's not something that is just being made up to call attention or whatever. It's a very serious disorder. Over 75% of the patients also carry a history of trauma, and depending on the study, anywhere from 22 to 100% can also be diagnosed with PTSD. PTSD is, again, a very serious, very toxic mental health disorder that is now getting the attention that it deserves. But for many years, people with PTSD were also treated, toughen up, get over this, and it's a very, very, very disruptive disorder to have, and treatable on the other hand, but it can really wreak havoc. Pain syndromes are seen anywhere from 22 to 89% of patients who have PNES. Dissociative disorders anywhere from 22 to 91%. Personality disorders anywhere from 10 to 86%. Primarily borderline personality disorder or obsessive compulsive personality disorder. And there's often medically unexplained symptoms. The main psychiatric issues, again, we've seen around 30% of patients with PNES have alexithymia, which is that difficulty to read your emotions. Slightly over 30% of the PNES sample that we looked at were using more of an emotional response to stress rather than using that task-oriented response to stress. All of these are things that can be treated, can be worked with. Alexithymia can be treated. The way in which you cope with stress can be modified. There's a researcher in Boston called Gaston Basselet who looked at a sample of patients, and he's the one who's been talking about this emotionally undermodulating, emotionally overmodulating patients, where what we're seeing is there almost seem to be two groups of patients. Let me back up and start saying, PNES, like we said, is a symptom, and it is, there are no one explanation explains why PNES developed. So there's no one particular theory. There's a lot of theories out there. There's a lot of researchers out there trying to figure out, okay, is it the trauma? Is it the depression? Is it the way that you respond to stress? So these are all things that we're just going to mention here so that you know it. But not everyone here will find that they're represented by what's being said. Okay. The most common thing that we do see is the overlap between trauma, PTSD, and PNES. But not everyone who has PNES has experienced trauma. So there's around 20% of adults who report absolutely no trauma in their life, and yet they've developed PNES. So these are just observations that have been made, research that's been done, but not everyone is going to fall in all of these categories. And Basselet has described that there seem to be two groups of patients. The emotionally undermodulating patients are patients that have a much greater reactivity, emotional reactivity, very poor tolerance to distress, so distress quickly overwhelms you, difficulty controlling affect, commonly are very depressed, anxious, borderline personality disorders, and with a long psychiatric history. So often a long psychiatric history, and then the diagnosis of PNES also came on board. Emotionally overmodulating patients that he described are patients that tend to use more emotional avoidance. They're very controlled, might tend to somatize, to develop physical symptoms that are not confirmed by a physician, and they have a much less identifiable psychiatric history. So there's not this long psychiatric history and then the PNES develop. Rather, there hasn't been much of a psychiatric history and then the PNES develop. And what I think what Dr. Beslat would say, I don't want to put words in his mouth, is that these patients, the overmodulating patients, are very controlled and have everything sort of together, and they've been going through life, managing until at some point, boom, something cracked. Versus the undermodulated patients who are the more understandable patient, where you would say, well, there's a long psychiatric history, so I can understand from a clinician's perspective, I can understand how this happened. So his research has been useful in that sense for understanding the overmodulating patient. So until recently, I started seeing patients with PNES 15 years ago. My first patient with PNES I saw 15 years ago. And at that time, there was no treatment for PNES. It was a disorder that was seen pretty frequently, same as now, in epilepsy monitoring units. And the billion-dollar question was, how do you treat someone with PNES? And everyone was like, I don't know, send them to a therapist. And then the therapists would receive these patients and send them back because they would say, they had a seizure in my office. This is a neurological patient. So it was this constant back and forth and ping pong effect. And honestly, there was no research on how you would treat a patient with PNES. So now, 15 years later, and we're still not, where we need to be, but we're way better than we were before. There are several treatment options. And what is reported through most of the series is that treatments will result in, and there's a variety of treatments, but of all these variety of treatments, elimination of seizures or a significant reduction in the numbers of seizures has been reported in about a fourth to half of the cases that are treated. I know that's not groundbreaking and fabulous for the other 50% or more. But what we are seeing is that with treatment, and there are many different kinds of treatments, in my sense is that different treatments are appropriate for different patients, for different histories and so forth. And of all these treatments, what we're seeing is that around 50% of patients will improve quite significantly. And you see their reduction of seizures or, you see their elimination of seizures or significant reduction of seizures. And of course, we always want, the goal is to have 0 seizures at the end. But sometimes to go from having 30 seizures a day, which can happen, to having 1 a week is a really significant reduction for the patient and makes a big difference. And as always, our goal is 0 seizures, but that's the direction that we're going in. Now, I say here, not all treatments are helpful to everyone. And some of the short-term treatments may not be sufficient for someone who has very severe psychological disorders and who are carrying a lot of additional psychiatric comorbidities. We'll talk about some of the short-term treatments that are now being used for PNES. And these treatments are basically targeting the seizures. But there might be other issues that need to be worked on for years or maybe for life. I often say that patients, there are worse things in the world than to be in therapy for life. It's nice, not nice, but as a therapist, I am also in therapy myself, and I enjoy going for an hour a week, and it's my time, and I talk about all the things that are coming up, in my life. And I think that for other people, for other patients, to be in therapy for the rest of your life may not be as terrible if it's managing to keep things in balance and under control. I do mention here that severe psychological disorders, complex trauma, and certain personality disorders do usually need to be in treatment for life. So treating PNES, this seems really basic, but this is often missing. First step is the conversation that the patient has with his or her neurologist, psychologist, or psychiatrist before being discharged from the hospital. Needs to be a thorough explanation of what PNES is, clear explanation that the patient understands. What is PNES? You're usually being told that the diagnosis that you've carried for all these years of epilepsy is wrong. You actually have PNES, so you need to spend time explaining what is that, that you've just diagnosed someone with. And also go over how it's treated. And ideally, the patient doesn't leave the hospital without a psychological referral in hand. It's really important because it's one thing to explain what PNES is, et cetera, and then say, go find help, right? Then if you say, this is a person who specializes in this disorder, or this is a place where we work together with them, or we have a communication with them, so I would recommend that you go here. So psychotherapy is the indicated mode of treatment once PNES diagnosis has been made. And there is a growing body of empirical evidence of certain treatments that are showing to be effective, including psychodynamic therapy. There are a number of studies on psychodynamic therapy, also known as psychoanalysis, but with some variations. Mindfulness-based therapy, cognitive behavioral therapy. And cognitive behavioral therapy is maybe, if you've been researching, the one that has the most publications out there, most evidence showing that it can be effective in treating PNES. Prolonged exposure therapy for dually diagnosed patients. EMDR, there is some empirical evidence as well of the utility of that. Then there are psychoeducational group interventions, so groups where you're not doing therapy per se, but you are providing education on PNES and different symptoms and how to deal with them. So for psychodynamic therapy, I'm giving a very, very general and basic explanation because it's humongous theory, but understands that psychogenic symptoms are produced by internal processes, usually resulting from traumatic memories, often from childhood, and emotional conflicts that are maintained at the unconscious level. And then that turns into a symptom that is a conversion symptom, a dissociative symptom, symptom of somatic difference. So you're having either an internal conflict or trauma that you're carrying around with you that instead of being aware and conscious turns into a physical symptom. So the goal of psychodynamic therapy would be to bring unconscious material to the surface and to promote change through insight. And you don't have to read all of this, but there have been a few studies that have looked at psychodynamic therapy, PNES, and I'll just focus on this one particular study. Looked at 37 patients. They were treated with weekly sessions of psychodynamic treatment for 12 months, and then 29.7 stopped having seizures completely at the end. 51.4% had had a decline. They do need follow-up data because often what happens with these studies is that they will follow a series of patients, report the results, and then boom, done. X number recovered. Well, you need to follow up 3 months, 6 months, 12 months, and so forth to see if those improvements were maintained or not. There's another interesting study, psychodynamic study. They did something called augmented psychodynamic interpersonal therapy kit. 2-hour semi-structured initial interview, up to 19 50-minute weekly or bi-weekly sessions, and of the 47 patients that followed up, 25% were seizure-free, and 40% had experienced a reduction of greater than 15% of the seizures, so as compared psychodynamic therapy. There's some results that show that it can be effective. CBT, cognitive behavioral therapy. What is it? Again, a very basic explanation. It operates on your current maladaptive thoughts, behaviors, and feelings. So thoughts, behaviors, feelings that you're having right now that are not serving a healthy purpose are targeted through CBT, checking your core beliefs of yourself, of others, of the future, and checking what is your behavior, your reaction to this. Can you change that behavior? Would it cause a change in the initial issue? And by acting on thoughts and behaviors and feelings, you begin to see changes in your life. Dysfunctional thoughts and behaviors related to conversion disorders are challenged and changed. Now, CBT is the treatment type that has the most research that shows that it's effective. And again, we have one study by Goldstein in which, and I'm just going to go over, I added this in here just so that you can see what the treatment would look like. It's a number of sessions. Session 1 is called treatment engagement, so basically the therapist is working to engage the patient. 2, reinforcement of independence. 3, distraction, relaxation, and refocusing techniques when you feel that the seizure is coming on. 4, a graded exposure to certain avoided situations. 5, cognitive restructuring, and 6, relapse prevention. So basically, these are each session is targeting a specific, it has a specific target in mind. And what they found was that they looked at treatment as usual, a treatment as usual group, which would probably mean nothing, would mean no treatment, would mean getting a diagnosis and then being on a waiting list for something, versus the patients who went through this treatment. And what they found was that the seizures went down significantly with the CBT treatment as compared to the treatment as usual. But they need follow-up data again. Okay, so we stop right there, and we need to know what happened afterwards. Kurt LaFrance, maybe you've heard of him. He is one of the authors on the book Getting Control of Your Seizures, or I may be misquoting the title, I don't remember, but he's one of the co-authors on that book. And he has been doing a lot of research on CBT here in the US. So the most important study that he has several, but the most important one that he's done so far looked at 34 patients, and they were assigned randomly to one of 4 branches. So one branch was medication and antidepressant, second branch was CBT, third branch was CBT plus the antidepressant, and the fourth was treatment as usual, which means nothing. It means a waiting list. You're on a waiting list, but you're not getting any treatment. And what they found is that the CBT that he was offering that produced a 51.4% reduction in seizure frequency. It was a significant reduction in seizure frequency. It improved depression, anxiety. They were looking at some of the other things that might be associated with PNS, quality of life, global functioning. And the one with medication also showed a significant reduction in seizures and in global functioning. So basically, both of these are showing good results as compared to treatment as usual and as compared to just medication, just antidepressants. What his treatment looks like is, and I'm just quickly going over what each session would be targeting. 1, making the decision to begin taking control, so you're talking to the therapist about this. 2, getting support, looking at your support network. 3, deciding about the drug therapy to be or not be on medication. 4, learning to observe your triggers. 5, channeling negative emotions into productive outlets. 6, relaxation training. 7, identifying your pre-seizure aura. 8, dealing with external life stresses. 9, dealing with internal issues and conflicts. 10, enhancing personal wellness. 11, other symptoms associated with seizures. 12, taking control and ongoing process. A mouthful. So these are 12 sessions. Each session has a target, and that's basically what they are doing in each session. I think the typical things that you will see in any therapy OB1, learning to observe your triggers. It should be in almost any therapy, not just CBT. And the relaxation training, very important to learn breathing techniques and different relaxation trainings. Here it is, Treating Non-Epileptic Seizures Therapist Guide. This is his most recent book from 2015. Follow-up data, he does have follow-up data, one of the few. They looked at 21 patients who had received this treatment. And what they found was that seizure reduction was maintained over 1 year in patients who did not have personality disorders. If the person had a borderline personality disorder for the most part, then that reduction did not occur or wasn't maintained. But what they did see is disability status also improved. Patients were able to become employed. And symptom substitution did not occur. That means simply that instead of having a seizure, you develop perhaps pain in the part of the body or another kind of stress reaction. So none of that seemed to reoccur. And this is his poster that he presented. Now, this is not to say that for personality disorders there is no treatment. That's the end. It just goes to say that, like we said right at the beginning, there are certain conditions that require much longer treatment than 12 sessions. So the 12 sessions can be effective in targeting the seizures, but then most likely those patients should continue in therapy and not just receive the 12 sessions and off you go. Now the other CBT treatment is PE, prolonged exposure. And this is the type of treatment that's designed specifically to treat post-traumatic stress disorder. It's a very efficacious treatment for post-traumatic stress disorder. It was developed by Dr. Edna Soa, who's in UPenn. And it has over 20 years of research on the effectiveness of PE for PTSD. They've looked at PE also treating PTSD with other associated conditions, depression, alcoholism, etc. And it's a very strong and useful treatment. Very basic. It is targeting just the PTSD. Now, this was our reasoning because we've started using PE now for about 3 years in our center. And our reasoning was that if around 25 to 100% of patients with PNES have PTSD as well, it would make sense to treat those patients with PE, which is an empirically validated treatment for PTSD. And our goal was to treat the PTSD symptoms and see if we could make a modification to the treatment, small modification to then treat the seizures as well. PTSD, for the most part, these are the symptoms of PTSD. These are the specific problems that someone with PTSD would have. There is a tendency after experiencing a very awful trauma, the brain naturally has certain behaviors that get activated because of this traumatic experience that was overwhelming and could not be processed. Avoidance behaviors. So what the brain will do is it will start to avoid any reminder of the trauma. Places, people, activities, thoughts, anything that might be a reminder to that trauma. So for example, if you were mugged outside of a 7-Eleven, then 7-Eleven might become something that you need to avoid. Might need to avoid if it was in the parking lot of the 7-Eleven, all parking lots. If it was, and so it starts to spread. Things that must be avoided to avoid the distress that comes when you see the 7-Eleven. And it reminds you of that moment. And emotional numbing is another thing that you see with PTSD. There tends to be like numbing, not feeling that intensity. And unfortunately, sometimes not feeling positive feelings, so not feeling happiness or excitement about things, but just feeling depression and unhappiness. That is present. Intrusive symptoms, often there will be nightmares, flashbacks, thoughts that reappear without you voluntarily bringing those thoughts up. Hypervigilance, or a constant sense of alertness, scanning for danger, and inability to relax, difficulty sleeping, difficulty resting, because you're on alert. And negative thoughts and mood. Often, after after the trauma, and after the symptoms start to develop, there's a tendency to say, you know, why have I developed these symptoms? Why am I being like this when other people have been loved and they haven't, you know, gotten like this? So there might be a sense of seeing yourself differently. I'm weak. My life has been destroyed. There's no hope for me. So these thoughts are also a very negative part of PTSD, and it really sort of keeps things going and stewing. So the core parts of the P is a very simple treatment. Since avoidance is basically the main culprit in PTSD, because you learn you've had to avoid all of these other things, thoughts and feelings and everything else. The core target is then to go from avoidance to confrontation. So you replace avoidance with exposure and confrontation, and you do that through two things. One, gradually of doing things that you have not been able to do. So it's not like you're going to jump into going to 7-Eleven right away, but because of the money I'm talking about. You will see, okay, what things have I begun to avoid as a result of this trauma? And let's start with something very small that I've been avoiding, and then you move further all the way to the point where you can go to 7-Eleven, because 7-Eleven by itself is not a danger. There's nothing particularly dangerous about 7-Elevens, but it has become associated to that. So you do in vivo exposure, which is doing things that you have not been able to do so far. Reading a news story, talking to someone about something, going to a certain place that you've been avoiding. And you gradually move yourself in that direction to everything that is not dangerous, that it is not, you obviously don't want to go to a very dangerous part of town and expose yourself to it. It's always worked together with the therapist to figure out gradually what things are safe to approach, and then you start regaining control over a whole part of your life. Imaginal exposure is just revisiting the trauma, the traumatic memory, in session. So in session for 45 minutes, you're going over that traumatic memory in detail, because often that has been something that you have not thought about. You have wanted not to think about it and to forget it. So it acts on all of these symptoms, all of the symptoms that we talked about. And basically, how does PNES fit in here? PNES, from our perspective, is an avoidance 2.0. So it's the dissociation. What purpose does it serve? It serves the purpose of getting you away from everything that was distressing you, because you have the episode. Not a conscious decision, not a conscious behavior, but that's the purpose that it's serving. So we've got, I know that I've got like 1 minute left, but we've got 2 different research projects that we presented with P, with patients who have PNES. And what we saw is that seizure frequency of 7 cases that we presented in 2015 had reduced significantly, as did post-traumatic stress disorder symptoms and depressive symptoms. And then we followed them up at different patients were followed up at different times. And they had maintained those improvements, except for 1 patient. And 5 of those 7 were enrolled in school or working, which is a major goal as well that we always want to look for in treating PNES. Second study that is now in press, 16 patients, 13 of the 16 after undergoing P had a complete elimination of seizures, and the other 3 reported a significant decline. I'm going to jump over this because otherwise I'm going to get clobbered. I've already said this, that all of these short-term treatments are effective for treating the seizures, but often not enough, and you're going to need additional treatment, and especially with complex PTSD, which is a very, very extreme type of PTSD, typically seen in, for example, persons who've had very chronic abuse or been hostages or prisoners of war, and extreme type of PTSD. For those cases, you will need long-term treatment. It just makes obvious sense. EMDR, there's been one study that looked at 3 patients who were treated with EMDR, 2 improved, 1 did not. There's a lot more research that's needed, obviously. Mindfulness, there was also one study that looked at, I think, 6 patients. Again, it's showing to be possibly a useful form of treatment. Group psychoeducation, again, can be an effective form of treatment. And basically, I'm just mentioning this so you see that there's a lot of research out there. There's a lot of researchers looking at these different ways to treat or to address PNS. And I'm going to have to leave here, but this is I'm going to have to stop right here, not leave. But these are recommendations for psychotherapists. And we have a few psychotherapists in the audience today. And for those psychotherapists, I would say, this is in your folder. And these are recommendations for how to deal with a psychogenic seizure in your office, which is sometimes something that psychotherapists have never seen or don't quite know what to do with it. So just recommendations. You can also share this with a therapist of your own, because you have it in writing, you have it printed out. These are recommendations for how to prepare for someone having a seizure in your office. Deciding with the patient what is the response going to be. If there's a need for a pillow or for physical contact, agree upon how that will be done. If the patient falls, then what to do. Ensure as much as possible that there are no injuries. The importance of teaching breathing exercises right at the outset, very useful. To not leave the patient alone, when to call EMS or when not to call EMS. Sometimes it's necessary to have someone come with someone to the therapy office. Sometimes it's not. So again, just all the possibilities that have come up in our experience and that we're recommending for future therapists to keep in mind. Grounding techniques. And then there are just a bunch of resources that you'll see in the handouts as well. There are professional resources for the professionals, the health professionals who are here. Resources for patients. Okay. I think I can take Sonia, one question. You're it.
Are you familiar with the app for prolonged exposure that was created by the VA?
I am.
Have you used it?
No, I haven't. Yeah, I am familiar. I just recently heard about it through one of the listservs. Yeah, have you used it?
I haven't, just because I've heard that there's a lot of kinks, a lot of problems with recordings that don't record properly and stuff. But
No, so I haven't. Have you trained through the U10 training or anything like that?
no.
No, okay. Because I can always ask through that listserv what's going on with that app. Okay. So I think I can't take any questions.